Ladies and gentlemen, we are now about to start the last session of the day. We kindly request all of you all to come back and settle down in the main hall. As the first event of the last session, we shall have the plenary lecture on extended antithrombotic therapy for acute coronary syndrome, who and how long, by Professor Aswar Zaman. I invite Dr. Yamali Amarasena and Dr. Rohan Paranamana to chair the session.
Thank you. If I could have the first slide on, please. Thank you to the Sri Lankan Heart Association for inviting me to give this talk. So as the title says, this is about extended antithrombotic therapy in patients with acute coronary syndrome. Who and how long? If you look at the pathophysiology of acute coronary syndromes, you know that it's caused by a plaque rupture and overlying thrombus. The risk from an acute coronary syndrome actually stays lifelong, as I hope to show you. And yet, most, if not all, of the early studies of antiplatelet therapy were commuted at 12 months. And this is why the guidelines, up until recently, had antiplatelet therapy for just 12 months. But if you look at where we are now in terms of recent trials, you can look that there are essentially 4 stages, okay? There are groups of patients in whom you would only give single antiplatelet therapy, some in whom you would give 3 months, some 6 to 12 months, and more recently, with the studies that I will talk about, there are certain groups of patients in whom you may consider extended, and by extended we mean just over 12 months of dual antiplatelet therapy. So what is the evidence in patients who've already had acute coronary syndrome? Well, there is old data. So if you look to the graph on the left, cumulative mortality in STEMI patients, and you look at 3 time points. So in black is 85 to 90, in orange 90 to 2000, and in the green 2000 to 2008. You have STEMI patients on the left, and you have non-STEMI. female, elderly. These are high-risk patients, and you should not have extended therapy. So rather than use any bleeding score that exists, I'm happy for you to do it. My personal feeling is that end of the bed test with a careful history of the patient is a far more powerful tool at individualizing than any scoring mechanism.
What about the other way around? If somebody has a greater thrombotic risk,
Yes.
multiple stents, things like that, would you, now there you'd want to actually extend it.
Yeah.
But what about when you want to, so now this is for bleeding risk, it can be, you might be shortening the 1 year.
That's a really good question. So the only thing that will kill a patient is bleeding. Okay, much more likely. So for the physician looking at the patient, what you have to do first and foremost is to identify high bleeding risk. The minute you have done that, you take these patients out from extended therapy, indeed even from 12 months therapy, and you would then use perhaps clopidogrel. Once you have excluded the high-risk patients, you're then into the realms of identifying patients at low bleeding risk and intermediate bleeding risk. And it's the low bleeding risk, it doesn't matter. If the high ischemic risk, just give extended therapy. You as a physician, you then have to decide on the intermediate risk where you can get away with extended therapy. So ischemic risk, I would say to you, is that as a physician, I don't care, because once they've come in with an acute coronary syndrome, 20% of patients will have a recurrent event, and all of these patients will have typically high ischemic risk. So the only thing that you and I have to do is identify high bleeding risk for treatment. Okay? And where clinical judgment is very useful is in the intermediate risk, where you have to keep a close eye. If there are low bleeding risk, extend the therapy.
If they need to be on oral anticoagulation, then again you have a confounding factor.
Yeah, so one of the other things I should have said, if you're going to extend therapy, a proton pump inhibitor to protect the gastric mucosa. If they're on anticoagulants, it's very clear, at least now, from the guidelines. Once again, you have to identify low, intermediate, high bleeding risk. If they are high bleeding risk, you continue anticoagulant, which whatever it is, warfarin or the new drugs, new oral anticoagulants, and then you will give either aspirin or clopidogrel for 1 month for high bleeding risk, and then you will remove the antiplatelet, okay, after 1 or 3 months and just have them on oral anticoagulants. If they are low bleeding risk, then the recommendation is that you have triple therapy for 6 months, and then you stop aspirin. You have oral anticoagulant plus clopidogrel for the next 6 months, and then at 12 months, all patients should just be on oral anticoagulants.
I have one more question. What about the old patients? Because on Pegasus trial, they excluded more than 75 years of age.
Yeah.
What is your opinion on older patients who had acute coronary syndrome in the past?
So once again, good question. So history is very important. Have they had a bleeding event prior to this admission? Okay, if they haven't, okay, then I would give extended therapy if their body weight is good, so above, we say 60 kilograms, then you can give extended therapy, but you would have to watch them carefully. So age per se is not a barrier, but they do need careful watching thereafter. Because remember, the elderly have not only high bleeding risk, but they also have high ischemic risk. Okay, so age per se is not a barrier unless they have one or more other high bleeding features.
And one more question. What about elective patients who undergo PCI or coronary artery bypass grafting? Do they need the extended treatment?
So if they just have routine PCI?
Routine PCI.
Elective?
Elective.
No. And CABG, also there's no evidence that extended therapy helps, but I would put a but in there. If you look at the COMPASS study with rivaroxaban 2.5 milligrams BD, it may be that we are seeing the first signs that extended therapy in your patients with high atherothrombotic burden may be of benefit. So that's a space that will be filled in over the years, but right now, stable PCI, stable CABG patients, there's no evidence for extended therapy beyond single antiplatelets.
Okay, thank you very much, sir. I think that's in the plenary session. I would like to invite Dr. Niyamali to hand over the token of appreciation to Professor Saman.
Thank you, sir. Thank you, madam. And next, ladies and gentlemen, will be the last program for the day. It is the case-based discussion. The panel is Professor Andrew Boyle, Professor Azwa Zaman, Professor Hardley Wilson, Professor Ricardo Fontis Carvalho. The case presenter will be Dr. Bhatia Ranasinghe. The co-chairs for this session will be Dr. W.S. Shantiraj and Dr. K. Arun Nithi.
Welcome to this session. It's going to be case-based discussion in general cardiology. We have three eminent cardiologists here to discuss the cases. The cases will be presented by Dr. Bhatia Ranasinghe. Bhatia.
Right. Thank you, sir. So these cases are actually not all are true patients who has presented over the last 6 months. So it will be interesting to learn the real patients that you manage, and all the most of the cases patients were problematic patients we had during management. Okay. Right. Okay. First patient, actually we have few cases lined up, about 15, so we'll try to get some message through cases and try to finish on time. So this is a patient who is 24-year-old. Can I get the slides, please? Right. Yeah, this is a 24-year-old recently married patient with a history of bioprosthetic mitral valve and a mechanical aortic valve. Replacement was referred to cardiology unit to assess fitness to become pregnant. And she maintains a therapeutic INR with a warfarin of 1 milligram per day. Right? So this is the echocardiogram. You can see that it's a bioprosthetic mitral valve. I don't know why they have done it, but anyway, it's with a mechanical aortic valve. Gradients are around 10 mean in the mitral valve, and the aortic valve gradient mean it's 19. So how do you assess? The questions are, how do you assess? Is it safe to become pregnant? And what is the plan of management? Over to the, yeah.
I can start? Yeah?
Yes.
Okay. I would like some more information. I would start the discussion for questioning why did he had a biological valve in the mitral side and a mechanical in the aortic valve. The second question is, this kind of discussions usually we do it before going to surgery, especially before of getting a mechanical valve, because the difficult part is to decide when the patient has a mechanical valve, how to deal with the anticoagulation, but we will move forward into this discussion, I think. And the third question is, regarding the echo that you did, You had a mean gradient of 10 in the mitral valve. How does it correspond in terms of functional area of the mitral valve? Because these gradients are a bit high. Can you give more information?
Well, the answer to the first question, why she had a biological valve for the mitral valve position, actually we also questioned should I have had a mechanical valve, but that patient has undergone and referred to us for assessment. So already the job is done, right? So you have to ask from the surgeon who has replaced it, why he has done it. And then question about the mean gradient in the mitral valve 10. So she clinically she was asymptomatic, right? And if you have seen the echocardiogram, LA is not dilated, right? Even though the gradient come as 10. Right?
What I'm saying is that in this kind of echoes, it is important to assess the functional area of the two valves, so that we can have a more clear information of the valve, if it is well functioning or not. So that is the main question that I would ask in the echo of this patient.
So mitral valve area was by Doppler was 1.5. Pressure half time.
Do you have an assessment of pulmonary hypertension at all?
And there's no pulmonary hypertension.
Okay, but that could also be important. In terms of pregnancy, of course, this is a discussion with the patient always, okay? You have to tell the patient that it has some risks, of course, but probably she will want to proceed with the pregnancy. In terms of anticoagulation, you always have this difficult decision, which is, on one side, it would be better for the mother to be on warfarin, but for the baby it's not that good. The problem here is that the patient has 1 milligram warfarin. If it was less than 0.5, it would be safe to proceed with the warfarin. In this case, probably the best option would be to change the warfarin to a low molecular weight heparin in the first trimester, and then go back again to the warfarin. At least is what I would do in this patient, although you know that this is a gray area with few studies, so it's not easy to recommend this. I don't know if the other members agree.
Okay, I agree with you, Dr. Fontes. I think a couple of things. One is that she's lucky to have the bioprosthetic valve in the mitral position and the mechanical valve in the aortic position rather than the other way around, as we know, because that would make it almost empirical or almost canonical that she would need to have significant anticoagulation throughout if she had the mechanical valve in the mitral position. But as he said, I think the first trimester is the concern for the Coumadin anticoagulation, so switching to the low molecular weight subcutaneous heparin through that time period would be safest, and then back to Coumadin anticoagulation all the way until the time of delivery. And then again, maybe some concern there for bleeding at the time of delivery, so it would just have to be watched closely at that point. But the other questions were, are there any other concerns other than the valvular gradients? Has she had any evidence of atrial fibrillation that would make us more compelled for anticoagulation throughout?
No. She hasn't had atrial fibrillation. She has a very good exercise tolerance. In fact, after careful assessment, since she has a very good exercise tolerance, her LA is not dilated, good LV function, we thought with the careful cardiac and discussion with the obstetrician, we should let her become pregnant, because she was 24 immediately after marriage, and in fact, she became pregnant. And we've, in fact, given the plan that if the warfarin requirement is less than 5 milligrams in the first trimester, actually, you can continue warfarin, the same dose. If the warfarin dose is more than 5 milligrams, then you switch to enoxaparin. So that's how our plan was. And then actually the next 2 months after, she became actually pregnant. Comes with the 8 weeks of POA. And So basically, that's how we handle the anticoagulation. So I like to ask from the expert panel at this moment, what are the cardiac conditions that contraindicate pregnancy? So anybody would like to answer the question? Professor Andrew Boyle or whoever?
This is always a difficult decision, depends on the patient that you have. In this case, I had no doubt that he is in a good condition to proceed with the pregnancy. He, as you said, the valve was functioning relatively well. He had a good LV function, so I have no doubt that she could go to the pregnancy.
Right. And the cardiac conditions that you have to be careful in pregnancy is, one is when you have severely dilated aortic root and severe LV dysfunction and severe pulmonary hypertension and and also obstructive heart disease like severe aortic stenosis. And those are the conditions that you have to be careful, and you have to advise against pregnancy because those are contraindications to become pregnant. So these slides will clearly give you how the anticoagulation should be handled during pregnancy. And it clearly shows that warfarin, if the requirement is less than 5, you try to continue warfarin during the first trimester. Right? If the warfarin requirement is more than 5, then you give, you can switch to enoxaparin, having facilities to monitor anti-10A factor levels, or else you can go to heparin. So that's how. I'm sure Dr. Santaraj will agree that there are worst case death reports in Sri Lanka due to this improper handling of anticoagulation during the pregnancy. Do you like to add, sir, about that?
Yeah. We had few deaths, maternal deaths, very unfortunate maternal deaths in this country with improper anticoagulation of pregnancy, because this anticoagulation should be decided by the cardiologists, obstetricians and the hematologists together. Not one person should decide. In one case, the obstetrician decided to change it to anticoagulation, and he put on a subnormal dose of enoxaparin. A patient was on 40 milligram twice a day of enoxaparin, and we have no facility to monitor the anti-factor 10A activity. So this lady came with mitral valve thrombosis, and actually she died because of thrombosis.
That is an issue. I would like to add this. If you decide to change to a low molecular weight heparin, either you should use at least 1.0 milligrams twice a day, or some people say that you should actually have a dosing of the anti-10A activity after the peak dose. The problem is, as you said, it also happens in my country. Not all labs have the possibility of having this kind of dosing of the 10A activity. So sometimes this is a difficult decision, but at least the 1.0 milligram twice a day should be given to these patients if you decide to switch.
Yeah, it should be strictly weight adjusted dose, and also I think it's better to add an aspirin as well in these patients.
Yes.
Aspirin.
And it clearly gives that second and third times you have to add aspirin in addition to warfarin. So in the interest of time, we'll go to the second patient. So this 16-year-old schoolboy developed chest pain and cardiac arrest while running. He was brought to Mathara General Hospital. That's about 30 kilometers from the hospital that I work in Galle. And the following ECG was taken in the emergency. And in fact, it was ventricular tachycardia. And then the subsequent ECG was that, after giving the cardiac shock. So you can see clearly the AVR ST elevation and ST depression in other leads. So he's 16 years old while running. And also, he gives a previous history. In fact, this first ECG was in fact transmitted to our electrocardiophysiologist in Galle, Susita, and for the VT, and in fact he was cardioverted, and then following subsequent ECG was this, and it was thrombolized. And we have asked to thrombolize given that ECG criteria, even though it's 30 kilometers, it could be more than 1 hour delay from that hospital to us, even can be 2 hours to organize ambulance and get it. So what we have advised is to thrombolize and transfer. So what is your protocol on bringing these patients?
So, well, I mean, at 16-year-old, that's very unusual. So all I would say is that immediately after a DC shock, the ECG can be, meaningless. So how soon after DC shock is this ECG? Immediately?
This was after about half an hour.
Half an hour.
Yeah.
And does he have an echo? Was an echo performed?
Sorry?
Echocardiogram?
Echocardiogram is not, it was not performed in Mathura, sorry.
Okay.
Yeah, we don't know about the data, what has happened in Mathura.
But this ECG is very interesting because if you look carefully, you have a generalized infra-ST in several derivations. You have an ST elevation in AVR, and this is strongly suggestive of left main disease, I would say, at the first look. So I think it was a courageous decision to give thrombolysis. The first option would always be to perform, to send the patient to the cath lab, but I think it is acceptable. Although, as you said, with 16 years old, it is highly unlikely that the patient has coronary artery disease. But
yeah. So, however, we thrombolized and we brought him to Karapitiya, and then patient was transferred to us, and the limited echocardiogram done from the ultrasound scan machine that was available to us in the cath lab. And this was the, this was the echo recorded from the phone from ultrasound scan machine. So you can see that the, only the inferior wall is working. Anterior wall, lateral wall, then the septum is dysfunctional.
Yep.
So it's a LMCA territory like infarct. So having just, because we thought we should image him first before we take him to the cath lab. And then this is limited images we took and did the angiogram. And angiogram was revealed this. In fact, we were looking for the left and we could not get the left. And finally, with the catheter, we saw that the left main also rising from the right. Right? Yeah. So you can see that, right? So left main also rising from the right. And in fact, it was proven to be anomalous left main rising from the right. So he has developed these symptoms while running. So what is the next line of management? In fact, what is the next imaging would you like to do?
CT scan.
No doubt, yeah.
Yeah, we have done the CT angiogram. Unfortunately, we don't have CT angiograms available in Karapitiya, the hospital we do work. And you can clearly see that. I don't have a pointer here, it's not working. So this is main pulmonary artery, and this is aorta. So this is the left vein running in between. And this is the right coronary artery. So it was a patient who had the left main running in between the pulmonary artery and the aorta. And when we retrospectively went and realized that this patient gives 2 years ago, he had 2 episodes of syncope while running.
Interesting.
2 episodes of syncope while running, and he was extensively investigated, evaluated by doing echocardiogram and also doing exercise ECG up to stage 5. I'm sure Dr. Sadanandan will agree because that all the records were there, and they all were normal. And this time he came with a fatal event. And after, in fact, when we were doing the careful echo, and we could locate that the left main, that you can see the color jet in between the aorta and the pulmonary artery.
Very nice echo, very nice image.
So that the left main is in between the aorta and the pulmonary artery. So what do you do?
Surgery.
Yeah, surgery. This is it's a very unusual case. Much more common to see left circumflex arising and going between the great vessels. Much rarer to see the left main actually going between these 2 great trunks. But yeah, you can't stent these patients. They have to have surgery. They have to have bypass.
So in fact, so he subsequently recovered the LV function. You can see that. He has recovered the LV function while he was in the ICU. He has recovered. And then we have subjected this patient to the surgery. In fact, left main was unroofed and reimplanted to the aorta, and subsequently his LV function dropped. And subsequent echo revealed that the EF was in fact 35%, and he came with heart failure. in fact, after the surgery, he did worse than before the surgery. So somehow or other we gave the maximum medication. I went home, but that was the truth. I have to tell, because I said these are all true patients, right? So patient undergone LMC reimplantation, and this is what I mentioned, and his EF was in fact dropped. I don't know whether it's ischemia or whether the left main was,
Did you redo the angiogram?
We didn't do angiogram. We did a secondly repeat CT coronary angiogram.
Okay.
And it was said it was normal. Do you have the picture? I don't have the picture, unfortunately, but it was told that it was normal.
So the left main stem was unroofed, and then
implanted to the aorta.
Into the left coronary sinus.
Yes.
Okay. And during the operation, they had no problems?
No. So this brings, actually, this is not the first case I have seen. This is actually the fourth case I have seen. In fact, during my foreign training, we had a similar patient who dropped with the VF, and in Australia, actually, in fact, and you can see that he got a RCA infarct. He came with the inferior MI, and there's a RCA occlusion distally, but left main again arising from the same, and it was going in between aorta and pulmonary artery. But he lived up to 55 years. So we didn't implant his left main, but tackled the RCA. So, you get these cases. And coronary anomaly is one of the causes for sudden deaths in young athletes. And that we have to keep in mind. So this brings us to a discussion. So what are the causes of exertional syncope? So if you get a patient who gets syncope on exertion, what do you think? Other than the coronary anomalies, what are the other common causes?
I can add one thing, which is there is a trial. There was a recent study, which was published in JAC, which made an autopsy of more than 300 patients who had a sudden cardiac death in the UK. And what they showed is that the second cause of death in these patients, of sudden death, or like syncope, like in this case that you had, was actually the coronary artery abnormalities. The great problem with this is one, which is it is almost impossible to diagnose this unless you do CT to all patients, which is not very common in this kind of situations. So this is a diagnostic problem that we usually have when assessing, there are hundreds of causes of syncope in young athletes, but when performing, like as you perform an echo and a stress treadmill test, usually you don't get the diagnosis. But actually, this is something that we should be aware of, because this is one of the second most important cause of sudden death in patients with less than 25 years. So it is an important echo message.
I agree. So essentially, muscle, valve, thrombus. Okay, those are the three things you need to exclude, and depending on age. Before you showed this, I would have said that it was a muscular. It would have been the top of my diagnosis, but that's the order that you have to go for exertional syncope in young people.
Yeah, good. I think in the interest of time, you have to think about obstructive heart disease like aortic stenosis, right? Hypertrophic cardiomyopathy, right? And also LV dysfunction. People can be syncopal on exertion. Arrhythmias like CPVT, catapolymorphic ventricular tachycardia, and coronary anomalies, pulmonary hypertension. People can be having syncope on exertion.
The first thing to think is, what is the age of the patient? Because if it is less than 35 years, the most common causes can be arrhythmic, or can be anomalous coronary artery origin, or a cardiomyopathy, the three main causes. If it is more than 35, the main cause is always coronary artery disease, and of course some of the rest. But it is very important to ask the age of the patient, because this age limit is really important.
Correct. So case number 3. This is a 41-year-old patient present with effort dyspnea and referred for echocardiography. This patient was in fact happened about 3 months ago. And she is hypertensive for last 7 years, and she was not on regular treatment. And echocardiography shows following findings, and let's see it. So she has undergone echocardiography 7 years ago and was diagnosed to have hypertension, and she was off treatment. And that time, 7 years ago, echo was totally normal, right? And this was the echocardiogram. When she came with effort dyspnea. Anybody like to comment? So, as a dilated aortic root, right?
I do a lot of echo. I do a lot of transesophageal echo because so it is
it's a transesophageal echocardiogram, yes.
What you see here is relatively easy to assess, although we don't have all the planes. Yeah. But you see very well that the cusps are thin. They do not coapt because there is an enlargement of the aortic root. So after seeing, although we still don't have the quantitative images, you see a very large jet in the origin of on the left ventricular outflow tract. And so I have no doubts that she has a severe aortic regurgitation. You can also see that she has moderate, at least, mitral regurgitation. I don't know if the LV is dilated, but it can also be functional dilatation of the LV.
LV is dilated and EF was 50%. Okay. Right? 50%. And the aortic root is 7 millimeters. Right?
How much?
7.
70.
You can see this here. It's 7.
Okay.
Right? And then about 10 minutes after the 2, you can see here nicely that the coaptation defect, as Ricardo mentioned, that because of the root dilatation, there's a defect in the middle and causing the CVAR. So it's basically aortic root dilatation causing CVAR, probably due to hypertension, I suppose, which was untreated. And
did you look for connective tissue disorders? I don't know how common it is in this country, but things like Marfan's, things like other connective tissue disorders. I mean, it seems very local. They're just at the root.
She actually, other than being hypertensive, she doesn't have other.
And how old did you say she was?
40.
It's 40. I think I agree with you.
That's
it's
rare.
Too young to have such a severe dilatation of the aorta due to hypertension. I think hypertension is
not hypertension.
Does not explain everything in this patient, I would say.
I too agree with that, but unfortunately we could not find any other abnormality in her. No connective tissue disorders.
Joints and everything.
No,
fingers.
all perfect. No joint pains.
High arch palate and things.
Nothing. Actually, she's obese, slightly obese lady, right? And she did not have any features of Marfanoid features or joint pains.
Yeah, because that is not a hypertensive aortic root. I mean, that aortic root there's a pathology there somewhere.
Yeah, could be. So patient developed worsening breathlessness and gone to florid pulmonary edema. And her blood pressure was 240 by 160. And lung bases had full of crepitation. I think Professor Andrew Boyle is the best person to answer this question. What has happened to her?
Well, she's in pulmonary edema, obviously, and she's got very high blood pressure and severe aortic regurgitation, so she needs vasodilators and diuretics, and she needs an urgent CT scan and a surgeon.
Yeah, it's a hypertensive emergency, right? Because her blood pressure shoot up, went to sudden pulmonary edema. And in fact, we gave diuretics, we gave GTN infusion, we started quickly, that's what was available in the CCU at that moment, and patient arrested. Right? And then next moment we were giving, in fact, CPR, cardiopulmonary resuscitation for 15 minutes, and fortunately she came back. And she was intubated, put on the ICU for 24 to 48 hours, and she fortunately recovered.
But you're not saying that the blood pressure has caused this? Because the blood pressure is a secondary response to her strong adrenaline.
Could be.
Yeah, so I'm not sure that the blood pressure is the cause. I think it's a result of her pulmonary edema and being in extremis.
Yeah. So how do you, so patient develop cardiac arrest, and this is what I mentioned. So what is the future definitive management? Her ejection fraction was 45, dilated aortic root, right? Mm-hmm. And then what do you suggest? Do you need further tests to evaluate and is she fit for aortic root replacement and AVR? Do we need further tests?
You need a
No,
CT.
this is a surgical emergency. I mean, this patient needs stabilization as quickly as possible, and then needs to go to the operating room for aortic root replacement and aortic valve replacement.
You can do a CT if you have time and if the patient is more or less stable to assess the rest of the aorta, of course.
We had time to do a CT because she was stable afterward. This is what the CT showed. You can see clearly the dilated aortic root. Clearly, you can see that. So, relatively, the arch is relatively spared, but it's the aortic root, right? So that's what we are planning at, to do a aortic root replacement and aortic valve replacement. So how do you counsel a patient when you have this EF of 45%, aortic root replacement, AVR? What is their surgical mortality risk?
Well, her non-surgical mortality risk is approaching 100%, I would say, in the coming week. So I think you've got to tell them it's an absolute emergency and they have to have the surgery or they'll die pretty quickly. The surgical mortality is quite high, but she's young and she's otherwise well, and it's quite an isolated aortopathy there. So I think she'll do quite well with surgery.
And what is interesting in this case is that she has all the criteria to do the replacement, because she has criteria due to the aortic enlargement. She has criteria because of the ejection fraction, which is lower than 50%. She has the criteria because the ventricle is severely enlarged. So from all the criteria for aortic regurgitation, you have all the criteria to go for surgery. So I had no doubt that it would be the best treatment option in this patient.
So actually, we see quite a number of patients who have this aortopathy, right? Patients who have aortic stenosis, patients with Marfanoid syndrome, patients we have, hypertension, various connective tissue disorders. So how do you monitor patients who have aortopathy, aortic dilatation, and what medications you will give on patients who are borderline cases? And when do you decide to operate? And what advices you would give to those patients? Would you like to answer? Yeah.
I can answer regarding the medication. If they don't have still criteria for surgery, there are now good trials, although they are usually done in Marfan syndrome, saying that using an ARB, usually the tested one was losartan, and also beta blockers can somehow delay the enlargement of the aortic root. The clinical trials are robust enough to recommend in this kind of borderline cases to recommend these therapies. I think so.
Right. Okay. Okay. So with the interest of time, we'll go. And there are clear indications to do aortic valve replacement in AR, which we already discussed. You can always go through the literature. I'm not going to waste time on this, right? And so we'll move on to the next patient. This 42-year-old male patient had an anterior MI in 2010. Right? He presented in May 2018 to our hospital emergency department with palpitation, and he was confused. And his ECG shows ventricular tachycardia. And he was cardioverted. This was the ECG he had on the ED. So he had MI about 5-6 years ago, and he presented to emergency department with this. He was cardioverted, so post-cardioversion ECG was this. So he had anterior MI in the past, right? Which I showed there are Q waves in anterior leads, and then T inversions in the anterior leads. So it looks like compatible with the old anterior MI, and presenting with the ventricular tachycardia 5 years down in the line after MI. So echocardiogram done shows EF around 45% and akinetic and thinned out anterior wall. You can see the echo here that the anterior wall was flat, right? And see the thinned out anterior wall, right? Thinned out anterior wall, right? So this is not an uncommon problem that we see day-to-day practice. Patients come after MI, even after revascularization, all that. We get patients with ventricular tachycardias presenting. So what is your future management? And so how do you maximize medications? Would you like to answer?
So the ejection fraction, I mean, how we manage him is dependent on his ejection fraction. He's a young man. What was his ejection fraction, did you say?
40%.
40%. Okay, so...
Probably lower, I would say.
Probably lower. I would agree
say a
with
bit
you.
lower,
Yeah.
but okay.
I think it's lower than 40. So optimized medical treatment. So, usual ACE inhibitors, ARBs, probably doesn't need diuretics at this stage, low-dose beta blockers, eplerenone or spironolactone, and see how he is symptomatically. What is the role of coronary angiography? Well, my personal feeling is that if he's asymptomatic, I would do a functional assessment of ischemia before I do coronary angiography. And if there is no ongoing ischemia, I wouldn't do coronary angiography. AICD is a difficult one. So in our practice, if the ejection fraction is less than 35%, and I think this man's ejection fraction is less than 35, then I think he should have AICD and possibly biventricular pacemaker as well.
In this case, I would put the ICD independently of the ejection fraction, because this is actually a secondary prevention indication for the ICD because the patient had a ventricular tachycardia, but no doubt regarding the rest. But I would always perform, usually these patients, not always, but sometimes they have the TV because they have ischemia. So usually, I agree with you, probably I would do first an MRR or an MRI to assess if it has any kind of ischemia or functional recovery, possibility of functional recovery. But I think all these patients usually should have a coronary angiogram to assess if there is something else that can be treated, because sometimes the trigger for this is ischemia.
Professor Wilson, any
so I would probably proceed earlier with coronary angiography, because we still don't know whether or not he had reocclusion that caused his ventricular tachycardia, and if not, at least ischemia. And I think sooner or later you're going to need to know what the status of the LAD is, presumably for the anterior wall, before you would proceed with AICD, which is what I ultimately believe he will need.
So my concern is that in a chap with atherothrombotic disease, that if we do coronary angiography to begin with, that he's likely to have lesions, which may be innocent bystander lesions. So my feeling is that functional test first, otherwise we may be left with a position where you have disease, but we don't know which one to treat if he has, let's say, multivessel disease. That's my concern.
I agree with you, although if I was on the emergency department, imagine that you were in the emergency department receiving this patient. You don't have yet all the details about the anatomy. You had a patient with a VT, you cardioverted the patient, you have these key waves in the anterior wall. My first suspicion would be myocardial ischemia. So as he said, I would send the patient first to the cath lab and then see what is the coronary anatomy. At least now it's easier to see it backwards, but if I was on the emergency department, at least it should be what I would do.
Agreed. What about amiodarone?
That is a great question, but I would say, first of all, the ICD, it will be my decision. Then the second decision would be, if beyond the ICD, if I would give him amiodarone. Probably yes, in the first months, I would give him with the ICD, and then reassess and try after some time to remove the amiodarone.
That's actually a great scenario, because it could be that this is all ischemia, and if so, then the ICD would be contraindicated within the first 6 weeks.
So suppose he has undergone angiogram and you found 100% blocked LAD and all the rest of the vessels were normal. So does it mean that we need to revascularize the LAD?
So
that's no point, right? Yeah.
Well, I don't think a functional test with that LAD territory would help you in the LAD territory. I would leave the LAD if it was occluded chronically. It's more about the ischemia in the other territories, and I find functional tests very difficult to interpret in this situation. So I'd go straight to an angiogram, FFR if you found a borderline lesion, and revascularise everything. I would put him on amiodarone. I think there is a role, whatever the substrate was, it modifies the substrate a little bit, at least in the early time. And then I think defibrillator is probably going to be the end game.
Okay, the take-home message is patients do die even after revascularization. MI patients after going home with ventricular tachycardia, which we don't see them, right, sometimes. So mainstay, optimize their heart failure, make sure they are on beta blockers, right. If there are indications for AICD, then you have to put them. So otherwise we'll be putting stents and sending them home, and they, in fact, they will be dying at home, right. So case number 5. So 45-year-old patient with a prosthetic metallic mitral valve replacement presented with ICH to emergency department, and her INR is 6. How do you manage? How do you tackle the anticoagulation? So it's a prosthetic metallic valve, INR was 6, and ICH.
What would you do?
So the first thing is to find out why her INR is 6. Has she overdosed on her tablets inadvertently? Are there other conditions? Has she been taking other drugs that may affect the INR? So I would need to dig deep to find out if there are any causes why her INR is 6.
Okay, so what I would do is, in this case, the decision is easy. In the way that after the patient is treated for the intracranial hemorrhage, it is because it is always a very high thrombotic risk patient, and he has to restart anticoagulation sometime. If it was an atrial fibrillation patient, that would be a difficult decision if you would restart or not the anticoagulation. Assuming that he has a prosthetic metallic in the mitral valve, you have to restart recirculation. I know because when we presented this in our journal club with my fellows in my department, there is a recent trial, a recent study that was done in Germany that showed that probably the best time to restart the anticoagulation, probably it can be after the 14 days, okay? Because if patient evolves more or less well, that would be probably the best timing to restart the anticoagulation. I think this case would be very difficult to decide again if the patient did not have a prosthetic metallic valve, and if he only had like atrial fibrillation. In that situation, there are several options, like closing the left atrial appendage. That would be probably my first option, or probably switch to a new oral anticoagulant because this patient, in this kind of patients, the reduction in the probability of intracranial hemorrhage would be more than 50%. So, but that would be in a patient without valvular atrial fibrillation.
So if a patient comes with INR of 6 and bleed in the brain, do we need to reverse this at this moment? Because if the brain becomes more important now, do we need to reverse?
The decision is easy.
Yeah,
the question is which agent.
Walking a tightrope here, but yes, you need to bring the INR down closer to the therapeutic range. Yeah. And then you need to know from your imagers, from your neurosurgeons, whether or not they're continuing to bleed.
So what would you do immediately? Which agent would you use to reverse?
Fresh frozen plasma, most likely. Yeah.
Would you give vitamin K?
Probably not.
And what would you aim for the INR with the FFP?
2 to 3, lower, yeah.
Some people, depending on the place where you have the intracranial hemorrhage, it is recommended to stop completely the anticoagulation for some time. As I said, for probably it can be up to 14 days in some patients. So this is always a difficult case. It depends a lot of things. Depends on your talk with the neurology and with the neurosurgeon, but it is always a team decision, I would say, these kind of cases. Yeah.
Actually, these patients are very difficult patients. We do see day to day, and there are no guidelines to manage these patients. So all the patients are individualized basis that we do manage. And actually, if the INR is very high, they come with the ICH, we generally reverse it, right? And then hope for the best, right? Not expecting that valve will look after by God, right? And after about 10 to 14 days, then we resume anticoagulation, but with a relatively low therapeutic INR. So that's what actually we do practice. But always these are difficult, it's patient-based and all that.
And another question would be, which kind of intracranial hemorrhage? Because if it was a subdural hematoma, the severity is much lower than if it was like a lobar hemorrhage or something else.
And in fact, it was aortic valve position. If it is aortic valve, then we are happy. If it's a mitral valve, then we are unhappy. So it's kind of which valve is replaced and all that. Right. So we have 17 minutes more, so at least we try to cover 3 more cases. 35-year-old patient known to have hypertension, referred to you with uncontrolled blood pressure. So he was given maximum 3 drugs, including a diuretic. So he's quite young, 35. 3 drugs was given with poor response. So how do you evaluate? What is the next step in management? So it's basically, by definition, is a resistant hypertension. So 3 drugs, including a diuretic, 35 years, but still the targets were not achieved. So how do you evaluate, and what is your next step? Yes.
Well, I guess at 35, the question is this essential hypertension or is there a secondary cause? And so you'd start your history and physical examination looking for those secondary causes. And then the second question would be, is this truly resistant hypertension or is this a lack of adherence to his medical regimen? Because most 35-year-olds with high blood pressure, it's lack of adherence in my experience.
Okay, I agree completely. And then regarding the next step. Interestingly, I don't know if you know, but there are now new guidelines for hypertension. The European guidelines have been presented like 1 week ago. They are not completely publicly available, but they were already presented. And for the first time, the guidelines they have an algorithm to treat not only the mild cases of hypertension, but also the resistant hypertension. So what they say is, first thing that you should start is a combination therapy, okay? Just a simple combination that could be an angiotensin blocker with either a diuretic or a calcium antagonism. When you reach to this level, when the patient has a diuretic, a blocker of the renin-angiotensin system, and a full dose of calcium antagonism, the third step should be adding spironolactone, because there is now very consistent data showing that in patients with resistant hypertension, true resistant hypertension, spironolactone should be the 4th antihypertensive drug to these patients. So this is the recommendation nowadays that will be presented officially in September this year. But this is the 4th step, should be the addition of spironolactone. Usually 25 milligrams is enough for these patients.
Right. So anyway, he was on a diuretic and a spironolactone. In fact, what sometimes we do is we monitor the ambulatory blood pressure, right? And sometimes, this is one of the patients who had resistant hypertension, but when you look the ambulatory blood pressure, it's reasonably controlled. It's not, there are spikes of pressure. Probably he was dreaming or something, But this is a true case. You can see that when you monitor the ambulatory blood pressure, it's all red. So it's not controlled. So things that you need to look is when you have a resistant hypertension, of course, make sure you put them on ambulatory blood pressure and make sure that it's really true hypertension or not. And then of course, make sure that the patient is adherent to the drugs, next step, right? And also advise on obesity, the physical inactivity, their diet and all that. And also go through the drugs, and then you have to look for secondary causes for the hypertension as well. So there's an algorithm to tackle. So
the important thing, is one of the things is that in a 35-year-old, you need to ask for side effects of the drug. So he may have not been taking it, and in that flow chart, we go on adherence, but in a 35-year-old, it's particularly important to ask about the side effects of drugs, particularly of things like beta blockers and diuretics. Yeah. And I think that's very important. So the patient has got to be involved in that decision-making. We can't follow guidelines per se, because all the trials, you'll not get a 35-year-old resistant hypertension, the trials that have led to the guidelines. So I think side effects of the drugs and finding out in detail is very, very important here.
Yeah. So, case number 7. So, this is a 60-year-old patient who has had a non-STEMI and undergone PCI to LAD with a drug-eluting stent 2 months ago and on dual antiplatelet drugs. And unfortunately, he has got a second event where he was diagnosed with carcinoma of colon and referred to you for a cardiology opinion prior to surgery. And his ejection fraction was 50% and no angina. So how do you assess? How do you advise on antiplatelets? So he's a patient who has drug-eluting stent was placed after a non-STEMI, right? And found to have a colonic cancer 2 months after the stent was placed. So the surgeon is asking about the surgery and also advice on antiplatelets.
Yeah. Okay, so so I need to know which type of stent it was.
Drug-eluting stent.
Yeah, but which generation, which one?
Science.
Yeah. Okay, how long?
2 months ago.
No, how long was the stent length? Length of the stent.
Length it was 28, 3 by 20.
And the width?
3 by 28.
3 by 28, okay. And then I need to know about the carcinoma of the staging of the carcinoma. Can it wait a month, or what's the staging of the carcinoma? How soon does this operation need to occur?
Good question, actually.
So essentially what I'm getting at is that with the Zion stent, the ongoing trial for 1 month is currently ongoing, but we have withdrawal data that shows that 3 months of DAPT is probably safe, okay? So that's cessation data rather than prospective data. So I would, in this particular instance, I would try and have 3 months of dual antiplatelet therapy if the surgery can wait, and then recommend surgery. If it's an emergency, then of course you have to do it with the proviso that we start DAPT as soon as safe after the surgery.
So I would agree. I think it would be a lot easier decision if we knew that they had had stable angina prior to stent placement, because that group is a lot safer also with early discontinuation of DAPT. But again, you're dealing with carcinoma of the colon, and I would agree that if you could wait for 3 months before discontinuing and then doing surgery, that would be ideal. And it looks like you probably could, but you know, obviously if they're bleeding or some other complications that would force your hand, then I would discontinue DAPT and go ahead.
Will you ask the surgeon to continue the aspirin and stop only the...
Yes.
No doubt, no doubt.
Yeah.
I would like to add one thing, because we also had last year, I think we had 3 cases like this in different timings after myocardial infarction in our department. And some practical tips, I think they are important, because we did several strategies in several patients. One thing that is useful for people who have smartphones and everything, there is an app which is very interesting because it's called Stent and Surgery. It is made by an Italian group which is very well known in this field. And you can put the type of surgery that the patient has, how long did he put the stent, and it automatically gives you an idea of what should be the preferred strategy. So that is a practical tip if you want to download this app, which is interesting. The second thing is, last year we had a case which was interesting because this was very similar, although the cancer was diagnosed 1 month after the myocardial infarction. And at that time, our decision was to do something that is also in the guidelines nowadays, which was to do a bridging with a new antiplatelet, which is Cangrelor. You know, Cangrelor is a new antiplatelet agent, which is very good because it has a very quick onset and offset of the antiplatelet efficacy. So what we did was we stopped the clopidogrel. This patient was with ticagrelor, not with clopidogrel. We did this bridging for some time with Cangrelor, and then we need to stop this about, it's enough 6 hours before surgery, and then the patient can go to surgery with the aspirin. We usually give the aspirin, and then this is like a bridge therapy for the P2Y12 inhibitor. So that can be an option, but probably, I don't know if you have the kangaroo here in
We
Sri
have
Lanka.
kangaroo,
We only have,
some
few months ago, we only have it for the last 6 months, I think.
And there are a series looking at glycoprotein 2B3A inhibitors in the same way as Cangrelor for about a week, bridge, preoperatively.
Yeah, that's what we did, more or less. We did, I think, 7 days of bridging, and then we did we stopped just before the surgery. It's a good option.
Actually, patient was operated with aspirin, and surgeons generally don't like clopidogrel on board when they operate. So patient was operated with aspirin, 100 milligrams of aspirin, and he went with the surgery.
2 months? Or
No. We asked them to wait for 3 months. Because it's not an emergency surgery. So that's what we did. So he went successfully. With the interest of time, I will try to move on. This is a patient with actually coronary calcium. Right? Inferior MI, actually we failed. We came with inferior MI and tried to open up the artery, we failed. We failed to place a stent. Right? So we medically managed, and then you can see the even with the several balloons, we don't have rotablate in our center, in an acute STEMI event, so we tried to place, but unfortunately we could not place a stent. So subsequently he has undergone a CT coronary angiogram which revealed a generalized coronary calcification. Anyway, he is doing well. So I'll try to, with the interest of time, this is a patient with diastolic dysfunction, bilateral atrial dilatation. I'll go to a very interesting case, just since we have limited time. This will be the last. Okay. This is a patient. It's a video, right? Right, 55-year-old patient referred for echocardiography due to breathlessness to assess LV function. Right? So patient was breathless and referred for echocardiography. The following observation noted just prior to the echo. You can see. So patient was lying in the bed. See what's happened to the abdominal movements. He was breathless. So nice. So what do you think? See now how he will get up very soon. He was breathless. What do you think? His echocardiogram was normal.
So it gets worse as he lays down. He is not that dyspneic, but he gets worse while lying down.
Yes, he was worse with lying down.
Okay.
Right? So we'll ask from the audience, what do you think? Sorry? Yes, good. It's a diaphragmatic paralysis, right? Patient was breathless because of diaphragmatic paralysis, right? And so when you do the echocardiogram, you can see that LV function and RA function was not bad, but the RA was compressed by the push lever, right? By the push lever. And in fact, patient was diagnosed to have this acute inflammatory demyelinating polyneuropathy, some inflammatory neuropathy, and patient was given immunosuppressions. However, Patient left diaphragm recovered, right diaphragm did not recover. Patient continued to have the same kind of symptoms. And this was the echo afterwards. You can see that the diaphragm, the liver is pushing the right atrium. And then we got the opinion, in fact, and then we sent this patient to, in the interest of time, I'll tell you the story. So we referred him to the thoracic surgeon, and he did a diaphragmatic plication, where the diaphragm was pushed down and then he attached it, pushing the liver down, and his breathlessness disappeared. And we had similar about 4 patients. Am I true, Dr. Sadananda? What do you think? There are about 4 patients, right? We noticed like this, right? So, you know, sometimes we do get patients outside cardiology that will affect the heart, right? Right? So we have to work out. Actually, we worked out this patient and he got better afterwards. So you can see the CT when the diaphragm was, chest section at the diaphragm, right diaphragm was raised, right, and pushing the liver upwards, pressing the right atrium. Right. Right. And I want to ask a final question because 2 minutes left. Right. 2 minutes left. These are interesting, you know, troublesome cases that we have to manage. 40-year-old patient, quick answer, had a coronary artery disease. Sorry, this 40-year-old patient, 35-year-old coronary artery disease. He had a LAD 50% stenosis. And his problem is, we can't put him on statins. He was put on aspirin and atorvastatin. The moment he put on statins, his CPK rises. Around 400, 600, he complaining of myalgia without exercise. Now we have stopped the medication. After even 3 months after, still his CPK is, you know, around 500. And we have done the neurophysiology referral and they said it's likely to be statin-induced myopathy. So how are we going to tackle this? He has a coronary artery disease, 50% LAD stenosis. He needs to be on statin and aspirin. He's on aspirin. So how we are going to tackle this problem?
How? I have some doubts that after 2 months, the cause of the CPK elevation is because of the statin. It's not what I see usually. But I think your question is regarding what is the therapy that you should recommend him. Yeah. The first, if he does not tolerate any kind of statin, the only alternative is to give him ezetimibe. And then to give them, if you have here, the new PCSK9 inhibitors, it can be an option for this kind of patients who are completely statin intolerant. Although, as you said, in this case, it's not usual to have this elevation in CK after two months of therapy. I think he stopped, yeah?
I think we have finished time. So, thank you very much.
Thank you, Bhatia, for the very interesting session on case-based discussion. May I thank Bhatia and all the participants, Professor Andrew Boyle, Professor Saman, Professor Hardy Wilson, and Professor Ricardo Fuentes. And may I ask Dr. Arunidhi to present the token to Professor Ricardo Fuentes in appreciation of his participation in this event.
Thank you, sir. With that, we have come to the conclusion of the second day of this 18th annual academic sessions. We cordially invite all of you to show your enthusiastic participation for tomorrow as well, from this premises, 8 a.m. onwards. Thank you. We bid you farewell. May you all have a wonderful evening.